Resuming debate, the honourable member for Kitchener-Conestoga.
Thank you, Mr. Speaker, and I want to also thank my colleague from Timmins, James Bay, for opening up this opportunity to discuss this important issue tonight. Mr. Speaker, I'll be sharing my time with the member for Cariboo, Prince George. I rise in the House this evening to lend a voice to a topic which lies heavily on my heart, and I know the hearts of all my colleagues on both sides of this chamber. This is not the time to be debating what could have been done or what should have been done, but rather we need to come together with a solution to the issue we are currently facing. There is no time to waste on partisanship when lives are at stake. Canadians need us to lead by example by coming together and rallying around this hurting community to help them in every possible way. In that spirit, Mr. Speaker, I use the word discussion rather than debate, because I am convinced that this House is eager to take action on the national tragedy that suicide represents. This is an epidemic that is larger than Attawapiskat, and unfortunately it is growing. It is not okay that the leading causes of death for First Nations peoples under the age of 44 are suicide and self-inflicted injuries. It is not okay that First Nations youth die by suicide 5 to 6 times more often than non-Aboriginal youth. And it is not okay that suicide rates for Inuit youth are among the highest in the whole world. This issue needs to light a fire inside all of us to do all that we can to not allow this epidemic to continue. There are many views on how this is best done, and Mr. Speaker, I share my view from some of the experiences I've accumulated over the past 10 years serving as a Member of Parliament. There have been many good steps taken to address this tragic issue of suicide, but much more needs to be done. As co-chair of the All-Party Parliamentary Committee for Palliative and Compassionate Care, I, along with NDP and Liberal colleagues, conducted a study on the complex issue of suicide prevention, and our findings are recorded in the report called Not to be Forgotten. What became clear is that suicide is a complex phenomenon with multiple, often intertwining and overlapping causes. The complexity of suicide makes it obvious that solutions cannot be reduced to a mental health approach alone, but must take all aspects of the person into account, including physical, social, cultural, and spiritual factors. One witness who appeared before a parliamentary committee was Dr. Anton Lenars, a psychologist and suicide researcher. He shared with the committee, quote, "Suicide is multi-determined. The common psychological factors are unbearable pain, cognitive constriction or tunnel vision, ambiguities about life and death, a mental health disorder, a weakened ego, a disturbance in a relationship or some other ideal like one's health or youth, rejection, aggression, and a desire to escape. This complexity calls for a diverse suicide prevention strategic approach. This is necessary to not only solve what is sometimes assumed to be primarily a medical problem, but also to address the deep taboo and its stigma, and to address the problem with specific vulnerable groups, such as First Nations and Inuit people, armed services personnel, youth and elderly, especially those facing end-of-life decisions. The complexity of suicide dictates the necessity of a parallel complexity of solutions. There is never the one solution. Therefore, not only a mental health approach, but a public health approach is urgently needed." End of quote. Research done by the Royal Commission on Aboriginal People, as recorded in our committee report, found that the culture of First Nations peoples was thrown into turmoil by the policies of colonialism. In this report, it was clear that the whole complex of relationships, knowledge, languages, social institutions, beliefs, values, and ethical rules that bind people together and give a collection of people and its individual members a sense of who they are and where they belong, plays a profound role in mental health and well-being. Prior to the breakdown of their culture, suicide was rare among First Nations people. However, as I previously stated, today, suicide among First Nations youth is at epidemic proportion. The development of sense of healthy identity is profoundly related to one's culture and its ability to reproduce itself in its members. Thus, the anthropological and sociological dimensions can deeply impact upon the psychological. It is important to be reminded that suicide intervention really does work, and many lives are saved every year. Despite this fact, Canadian response is mainly due to the efforts of individuals and private groups who strive against the tide with very few resources. We have many great examples of local groups across Canada who are doing heroic work in preventing suicide. Mr. Speaker, when I first heard the news of the 11 suicide attempts in Attawapiskat, my heart sank, and I immediately remembered an incident from 2011 when I was contacted by Tana Nash of the Waterloo Region Suicide Prevention Council. She informed me of the fact that 3 suicides had occurred in 3 different high schools in Waterloo Region in 1 week. Help was urgently needed. At that moment, I knew that I would want to do something to deal with this issue, albeit my attempt would be less than adequate. I knew that something must be done to address the tragic loss of hope, especially among our young people. To that end, I embarked on drafting Bill C-300, an act respecting a federal framework for suicide prevention. As a nation, we have not done enough to implement a coherent program of suicide prevention. Some provinces have begun to make great strides, especially Quebec. Yet in general, efforts to prevent suicide are still a patchwork, depending on the generosity of individuals, many of whom have been personally impacted by suicide. This is why it is so urgent that the government implement the federal framework on suicide prevention as soon as possible. With its immediate implementation, we will be able to give the much-needed tools and resources to the groups on the ground that they so desperately need. Bill C-300, when fully implemented through the Public Health Agency of Canada, will provide guidelines to improve public awareness and knowledge about suicide. It will disseminate information about suicide, including information concerning its prevention. It will make publicly available existing statistics about suicide and related risk factors. Mr. Speaker, this was one of the weak points that many of the groups that came to our committee pointed out. The statistics relating to suicide are so old and so out of date that there's really no way to plan forward going ahead. Promote collaboration and knowledge exchange across domains, sectors, regions, and jurisdictions. Define best practices for the prevention of suicide and promote the use of research and evidence-based practices for the prevention of suicide. The principles embodied in Bill C-300 can be contextualized and individualized to communities depending on their unique circumstances. I want to underline that fact. This is not a bill that will tell communities how to do it. My colleague earlier pointed out that we need to give communities the ability to contextualize within their own communities. Furthermore, Safe Talk training for all frontline service workers and volunteers on reserve would be a major investment in proactive prevention of suicide. Community members such as teachers, doctors, nurses, coaches, pastors, club leaders, and many more are in a unique position to recognize the early warning signs that would be able to ask the right questions that could very well lead to saving a life. I'm certain that everyone in this chamber can tell us how they, their family, or a member in their community has been negatively impacted by suicide. Each of us knows someone whose sense of hope was overcome by despair and who ended their life by suicide. But, Mr. Speaker, we know that suicide does not end the pain. It simply transfers it to the family, to the friends, and community. And this particular community that we're discussing tonight is currently in extreme pain. So now is the time to do all that we can to deliver hope. Evidence is accumulating that when Aboriginal communities design their own interventions, typically based on traditional cultural values and practices, the efficacy of these interventions is high. Therefore, there is hope, but much more needs to be done. We need to offer hope to those who are facing this unbearable pain and who subsequently descend into a state of hopelessness and despair. Hope is dependent on having a sense of connection to the future, even if that future is short-term. Hope is the oxygen of the human spirit. Without it, the spirit dies. Mr. Speaker, I'm a person of hope. The very fact that this important discussion is happening tonight in the House of Commons in Canada is a huge step forward in providing hope. To my brothers and sisters at Attawapiskat, we stand with you. to provide immediate practical help, and please know that you are in our thoughts and prayers. I pray that you will know that your life has value and meaning. You are loved by your family, your friends, your fellow Canadians, and by your Creator. Thank you, Mr. Speaker.